Good evening, students. Am I audible? Yes. Okay. So, shall we start the session? Yes. So, today the session, good evening all. Thank you. So, today's the discussion will be about the previous year questions in pathology in the INI-CET. So, I have taken care that to include all the topics to cover mostly from general path, hemat, and also from systemic path, the basic and most important things. Already certain things we have covered in our previous discussion as well as in our test and discussion. So now this will be a quick recap of those things, and also additional new things which we have left in those sessions we'll cover in these things. Okay. So now we'll be going on to the first question. Toluidine blue is used to stain. Yes. What is the answer for this? So to start with, we have started the first most easiest question. Yes. Yes. Very good. So this is a simple question. So toluidine blue is used to stain mast cells. Mast cells. Actually, they have given the image also. So what is the special things about the mast cells, you know? So what is the actually tissue you are calling this as mast cell? What is the counterpart of mast cell in the blood? In blood, what you call as some cell, and the counterpart in the tissue, you are calling it as mast cell. Which cell? Yes, mast cells are nothing but actually the counterpart in the blood is basophils. Yes, the 0 to 1% is the basophils. So that basophils in the blood and the tissue counterpart is the mast cells. Now the other questions we can ask from this mast cells are what are all the other markers that can be used for mast cells? Yes, it is tryptase. The other recent markers which are updated are CD117, that is c-KIT, CD30. These are all the other markers used to highlight the these are the other markers and the special stains used to highlight the mast cells. And another special thing about this toluidine blue is toluidine blue actually it is called as metachromatic stain. What do you mean by metachromatic stain? Actually, the dye will be of one color and the stained part and the stained cell will be of the other color. You can see from this image, actually the dye is, the stain is in the blue color, and among this blue color, you can see this purple color mast cell. So mast cells are stained in purple color and the background is appearing blue in color. So this property is called as metachromatic stain. And also you will be knowing that mast cells are involved in type 1 hypersensitivity reactions. Okay, so these are all the MCQs which can be asked around the mast cells. Okay, so this is because about the stain. Just we'll have a quick recap about the stains used in other stains like Mason trichome for collagen. Van Giesen stain is for elastic fibers, and to demonstrate the reticulin fibers, especially in the bone marrow biopsies as well as in the kidney biopsies, you want to demonstrate the reticulin fibers. So you will use silver methenamine stain. And obviously everybody knows that for fat, we use oil red wool and Sudan black. And muscle striations you want to demonstrate, you use PTAH stain. And for fibrin, they call it as MSB, that is Martius scarlet blue. And PAS, one of the most commonly used stain in pathology, that is the periodic acid shift stain, which usually stains this glycogen, neutral mucin, and also it can stain your basement membrane, which can be highlighted in the kidney biopsies, basement membrane. So basement membrane and also the fungal elements also can be stained by this PAS. Yes. Alcian blue, one of the places we commonly use the Alcian blue is in the Barrett's esophagus. So Alcian blue stains the acidic mucin at a pH of 2.5. And Congo red for amyloid. And Vancomycin, the most commonly used stain for calcium, and alizarin red is the most specific stain used for calcium. Yes. Adding on to the furthermore list, I'll be sharing this PDF with you. Prussian blue stain is used for iron, hemosiderin pigment, and Mason Fontana. Mason Fontana is for melanin, Austen for copper, and modified rhodamine, and that is a method of choice. Don't confuse this with rhodamine with rhodanine. Okay, rhodanine is something different. Fluorescent dye, that is a. This is rhodamine for copper. Then toluidine blue mast cells we have just seen, and GMS PAS, as I told, it is used for fungal elements. And Shikata arsine stain, that is a hepatitis B antigen, which is that nothing but the ground glass hepatocytes, which is the ground glass hepatocytes. You can see in chronic hepatitis B infection, which contains the HBsAg particles, which can be highlighted by this Shikata arsine stain. So only that stains are also called as Shikata cells. The cells are also ground glass hepatocytes. The other name of ground glass hepatocytes seen in chronic hepatitis B is called as Shikata cells. Then music arm in India in preparation, microbiology, cryptococcus, and this is all the microbiological recap. That is Vathin Stari. Vathin Stari is also a silver stain. Vathin Stari is also a silver stain, which highlights this pyrocates. And calcofluor white for acanthamoeba, Zeal-Nielsen Kinyon for AFB, and Machovala stain is for rickettsia. That is a quick recap about the most commonly asked and most usually done special stains in pathology. Moving on to the next question. Cell inside cell appearance is seen in. Yes? What do you think? Cell inside a cell. That is, one cell is inside the other cell. So what is this appearance is called as? Yes, this is called as enthosis. Yes, very good. You have told this enthosis. Yes. So from the options, you can easily rule out necrosis and apoptosis, because necrosis and apoptosis are irreversible cell injury, and necroptosis is nothing but it combines the features of necrosis and apoptosis. So enthosis, what is this enthosis? Normally, when every cell, one cell is connected to the other cell by this E-cadherins. So E-cadherins. So when the E-cadherins are lost, the cell will treat the adjacent cell as a foreign one. E-cadherin is a glue-like thing, E-cadherin. Yes, this E-cadherin is a glue-like structure which holds the two cells, So what happens? So when this E-cadherin is lost, the cell will not recognize the other cell as its own cell. It will treat itself as a foreign cell. So it will try to engulf the cell. So this process is called as enthosis. That is, one cell is engulfing the other cell. And what is the difference between this enthosis and other terms, similar terminology? Emperipolysis. So emperipolysis is nothing but a big cell, say for example, a megakaryocyte. A big cell, say for example, a megakaryocyte. A megakaryocyte will actually, in the surface area, the cell size is much more bigger in megakaryocyte, no? So there will be some neutrophils or the lymphocytes which will just pass through the cytoplasm of the megakaryocyte. That means what? The cell inside the neutrophil is also inside the megakaryocyte, but this cell is live. This cell is live. In emperipolysis, the inside cell is live. But in enthosis, the inside cell is dead. This is very important. Okay. So enthosis, the inside cell is died. And in emperipolysis, the inside cell, it is also cell within cell, but here the cell is alive in case of emperipolysis. What is this enthosis actually plays a major role? Enthosis plays a major role in cancer. Okay, cancer. What happens? Actually, it plays a dual role, opposite roles. That means it protects against the cancer and also it stimulates it helps the cancer survival. How this dual effect can be the enthosis, that is, a cell cannibalizes the adjacent cell. That is, it kills the adjacent cells. That means what? An immune cell can kill the adjacent cancer cells. Thereby, it protects against the cancer. Yes? Enthosis protects against the cancer. Immune cells can kill the neighboring cells. Okay, enthosis. But how it helps in the survival of the cancer cells? The tumor cells, the cancer cells will keep on dividing. The cancer cells will keep on dividing and it needs a lot of nutrition. So what happens? The cancer cells will cannibalize, will take the nutrition, will engulf the nearby cells and thereby it keeps on surviving. The cancer cells cannibalizes the neighboring cell. So thereby it keeps on surviving. So enthosis protects against the cancer and also favors the cancer formation. So these are the things we should know about enthosis. Okay. Moving on to the next question. All of the following are true about renal cell clear cell carcinoma except. Yes, I know that two options may be right in this thing. Okay, I'm giving you a clue for this. This is the exact words I am putting in terms of the previous year. Since it is a discussion of the previous question, I am putting it as the exact things. Okay. So what are all the options do you think are the false here? All of the following are true. That means two statements are true and two statements are false. What do you think are the false statements here? Yes, what do you think? It is sporadic in nature. Yes, now let's analyze the one by one the options. So renal cell clear cell carcinoma, it is a sporadic in nature. Yes, it is sporadic in nature. Mostly it is sporadic in nature, but also has familial occurrence. In familial, what syndrome you are aware of? Clear cell carcinoma, renal cell carcinoma, clear cell carcinoma, familial. If I tell you familial, then what syndrome will come to your mind and what gene will be come to your mind? Yes, you will be thinking of VHL. That is von Hippel-Lindau. Von Hippel-Lindau gene you will be thinking. And mutation in this gene, actually it is von Hippel-Lindau, 3 letters VHL. So it is located on chromosome 3, but please remember here there is 3p deletion. 3p deletion. So von Hippel-Lindau, 3p deletion leads to renal cell carcinoma. But in the option 3p, p means it is short arm. P means petit in the French, which means a short arm. But in the option, they have given it as long arm deletion. So this is wrong. Now let us see the other option. It arises from the distal convoluted tubule. That is also a wrong option. And it arises from the proximal convoluted tubule. Most probably, most likely, most commonly, clear cell carcinoma arises from the proximal convoluted tubule. So these two options are wrong. And tumor cells contain glycogen and lipid because the name says that it is a clear cell carcinoma. Clear. So in the histopathology, if any cell is looking like a clear or white, empty looking cell, that means what it contains, it is not taking up the hematoxylin and eosin stain, it appears clear. So it contains a lot of glycogen and lipid, This statement is also right. So these are the two options. So in the question, they would have asked you which the option is A, B, something like that. So these two are the wrong options and the other two are the right options. Okay. And what is the nuclear grading used in RCC? Nuclear grading used in RCC, it is Fuhrman nuclear grading. Fuhrman nuclear grading is the RCC staging, nuclear grading. Okay. So which RCC is bilateral, multifocal, most angio-invasive? So all these things, the answer is papillary RCC. Remember, papillary RCC also you can get somoma bodies. Papillary RCC also you can get somoma bodies. Okay. And so please remember, if you get RCC in a young person, you will be thinking of XP11 translocation. So remember, MET oncogene mutation is seen in papillary RCC, medullary type of renal cell carcinoma is seen in patients with sickle cell anemia, And also remember, RCC can present with paraneoplastic syndrome. Which paraneoplastic syndrome? It is usually polycythemia. Renal cell carcinoma can produce a lot of erythropoietin. So this causes a paraneoplastic syndrome. So the patient can be presenting with increased hematocrit, PCV, and also hemoglobin polycythemia as a paraneoplastic syndrome. Renal cell carcinoma and hepatocellular carcinoma have carcinomas with hematogenous spread. This is also the possible questions which can be asked from your renal cell carcinoma. Another question, renal cell carcinoma with worst prognosis. It is collecting duct. Okay, collecting duct, that is the Bellini duct carcinoma with the worst prognosis. Okay, worst RCC with worst prognosis. Okay, so these are some of the MCQs which can be asked from RCC. Moving on to the next question. Which of the following is true about autophagy? Autophagy, yes, it is nothing but cell eating its own content. Okay, autophagy is nothing but cell eating its own content. It was a question update. It was the recent topic updated in the recent edition of the Robbins. So they have started the questions, asking the questions from the autophagy. So autophagy, cell eat its own content. Why cell has to eat its own content? It's like a cell when it is deprived of nutrition. The cell wants to survive anyhow. So the cell eating its own content. Now let's see the options. Autophagy is activated when there is excess protein gets aggregated inside the cell. Do you think it is right? No. When the cell is in a protein deprivation, when the nutrition is not enough, when the cell is not getting enough nutrition, then the cell eat its own content, so has to survive. So autophagy is activated when there is low protein inside the cell. Okay. So this option is a wrong one. Autophagosomes can fuse with any cell organelles. No, it cannot fuse with any cell organelles. Autophagosomes can fuse with the lysosomes. Okay, lysosomes, which contains the suicidal enzymes, proteases. So this autophagosomes fuses with the lysosomes, and this results in formation of the autophagolysosome. So this is the correct option. Autophagosome is a double membrane bound structure. It contains a double membrane bound structures. So similarly, please remember, autophagy plays a major role in neurodegenerative diseases like your Alzheimer's disease, Huntington disease. You can remember Alzheimer's. The autophagy is accelerated. Autophagy is accelerated in Alzheimer's disease. Okay. And in Huntington, there is impaired autophagosome formation. Okay. And please remember, sir, there are some infectious agent like your herpes simplex virus and also tuberculosis, Shigella. The elimination of these agents from our body, autophagy plays a major role in the elimination of these agents. So if autophagy is not there, then there is more susceptibility to these infections. Okay. Similar to enthosis, autophagy also protects against cancer, and also it helps in the cancer survival, similar to the mechanism of your enthosis. Okay, so these are the important things. And autophagy can also play a role in the inflammatory bowel diseases. So these are the MCQs which can be framed with this autophagy. Okay. Moving on to the next question. Differential expression of the genetic material in parents is called as, yes, what do you think is the answer? Differential expression of the genetic material in parents is called as. What do you think is the answer is? Yes. So that is the genetic material One genetic material is expressed in one parent and in the other parent it is not expressed. So such kind of thing is called as genomic imprinting. Genomic imprinting. So I'll give you the examples and the diseases, then you will be in a better position to understand about this genomic imprinting concept. Imprinting. Imprinting is nothing but it is silencing. It is silencing. All of us know that every gene will be having two alleles. Okay, any gene will be having a two alleles. Okay, one is a maternal allele and the other is a paternal allele. Now let's see, take two diseases. One is Angelman syndrome and the other is Prader-Willi syndrome. Okay, other is Prader-Willi syndrome. In Angelman syndrome, what happens? The gene involved is UBE3A gene. So what is this? Normally, I'm talking about the normal thing. Normally, this gene is imprinted on father's chromosome, paternal chromosome. That means what? Imprinted. Imprinted means silenced. Imprinted means silenced. So normally it is silenced in father's chromosome and it is expressed only on the mother's chromosome. So this gene is expressed only on the mother's chromosome. So imagine it is not expressed in father, but it is expressed only on the mother. That means what? Imagine if there is a maternal deletion, if mother is also not expressing, that means what? This child will not have this gene at all. So this condition, that is a maternal deletion, causes this Angelman syndrome. Angelman syndrome. Take the example of the other disease, that is Prader-Willi syndrome. So here the gene involved is a SNRP gene. SNRP gene. This SNRP gene is normally imprinted on maternal chromosomes. Imprinted, that is, it is silenced on maternal chromosomes and it is expressed on the father's chromosome. It is expressed on the father's chromosome. So imagine the same condition. If it is not expressed on the father's chromosome, if it is deleted from the father, then what happened? So it is the Prader-Willi syndrome. So you can remember paternal deletion, Prader-Willi syndrome. Maternal deletion, Angelman syndrome. For all of us, our mothers or angels. So you can remember mother deletion, Angelman syndrome. Okay. And what the examiner can give you, the subsequent exams, you can give the questions, how it can be framed. So the clinical features can be given. And very characteristic of this Angelman syndrome is inappropriate laughter. The child will be keep on having a very smiling face always. So this is called as a happy puppets. That is, they keep on inappropriate laughter. So this thing is called as a happy puppets seen in Angelman syndrome. You can remember, angels are always will be having a smiling face. So Angelman syndrome, happy puppets. In addition, the child can have an ataxic gait and seizures also. Seizures also. Coming to Prader-Willi syndrome, the child will be having a mentally retardation, short stature, and very important thing is hypotonia. Tonicity will be less. And profound hyperphagia, plenty of appetite will be there. So the child will be keep on eating. Okay, profound hyperphagia will be there. This lead to obesity. But the hands and feet will be very small, and the child will have hypogonadism. So these are the possible things which they can ask you about genomic imprinting. Okay. Now moving on to the next question, one of the important and most repeat topic from our INI-CET is about the thyroid tumors. So let's see this thing. A 35-year-old male presented with a painless, slow-growing neck swelling. His cervical lymph nodes were enlarged and surgery was done, and the histopathological image is shown in the figure below. And which of the following is not true about the lesion? So they are asking you, so what is this tumor? First you have to identify, and then you have to say me what are all the things which is true and which is not true. That is a question asked, which is not true about this condition. And what is this tumor? Is, by the way, what is this tumor? What do you think? How the cross section is there? And the cross section, you can see how these things are there. Can you appreciate? These are all like the finger-like projections. Yes, finger-like projection, anything in the pathology, we are calling it as a papillae. And what is the characteristic feature you are seeing here? See the typical, this papillae will be before that, the typical papillae. Each papillae is having a fibrovascular core, that is a blood vessels. Blood vessels are running. Blood vessels are running in the center of the core. Blood vessels are running in the center of the core. So these are the papillae, these are the blood vessels. And what are all the things you can see here? The nucleus normally will be having a dark chromatin. And see here how the chromatin is. The chromatin is very clear in color. See this. This is a clear chromatin. Clear chromatin. Otherwise, this chromatin is called as a ground glass chromatin. And what is the famous terminology for this ground glass chromatin? Yes, what I? Yes, you are right. It is orphan Annie nucleus. Orphan Annie nucleus. That is a cartoon character, famous cartoon character with the empty looking eyes. So this nucleus is called as orphan Annie nucleus. And this tumor is nothing but it is the papillary carcinoma thyroid. Papillary carcinoma thyroid. And remember, students, papillary carcinoma thyroid, one of the places commonly you will be getting somoma bodies. Yes, somoma bodies. So we have come to a conclusion analyzing the morphology of this tumor. We have come to a conclusion that this is papillary carcinoma thyroid. Now let's see what are the things. Nuclear features or characteristic of this tumor. Yes, just now we saw that it has a very characteristic feature. And this tumor carries an excellent prognosis. Yes, this carries one of the best prognosis. If you do surgery, definitely they will be having a best prognosis. And a rapid spread to lymph nodes. Yes, papillary carcinoma, lymphatic metastasis is very common. Okay. And remember, sometimes the metastasis may be the first presenting feature, so that even sometimes even the thyroid swelling may not be visible. The patient may present with a lymph node swelling first. So this condition is called as occult primary. Okay, occult primary. Okay, so the primary will be occult, but the patient will be presenting with a lymph node swelling. And coming to the next option, FNAC is not diagnostic. Please remember, FNAC is diagnostic in case of papillary carcinoma. In which carcinoma, FNAC cannot say you that this is a carcinoma. In which thyroid carcinoma? Yes, you know the types of thyroid carcinoma: papillary, follicular, medullary, and anaplastic. Very good. In follicular adenoma or follicular carcinoma, you cannot say by FNAC because very good. So follicular carcinoma will have capsular and vascular invasion, but your FNAC cannot identify. FNAC is like aspirating the single cells. So FNAC cannot say that whether there is a vascular invasion or capsular invasion. Only a biopsy or a histopathology section only can say you that FNAC means that it is a follicular adenoma or follicular carcinoma. FNAC cannot say this, but FNAC can say that this is a papillary carcinoma. Okay. Now moving to the other thyroid tumor, that is the medullary carcinoma thyroid. Please remember that possible MCQs which can be asked from medullary carcinoma thyroid is the cell of origin is parafollicular C cells. Yes, parafollicular C cells. And what is the tumor marker for this medullary carcinoma thyroid? Yes, it is calcitonin. Remember, medullary carcinoma thyroid. Medullary carcinoma thyroid, the tumor marker is calcitonin. And another important thing, though calcitonin is a tumor marker, but hypocalcemia is not a prominent feature. Hypocalcemia is not usually seen. And please remember, medullary carcinoma thyroid can arise in the setting of the Men's syndrome. Okay. And medullary carcinoma, another important keyword, what you will be remembering. Amyloid stroma. Amyloid will be there in the stroma. Amyloid will be there. And another MCQ, medullary carcinoma thyroid, the place where you will be doing prophylactic thyroidectomy. Yes, if you are examining a familial medullary carcinoma thyroid, prophylactic thyroidectomy is indicated because 100% there will be a chance of malignancy will be there. Okay. And the next thyroid cancer, that is the anaplastic carcinoma. Anaplastic, no differentiation at all. That is a tumor with the worst prognosis. Okay. Thyroid cancer with a very aggressive course and the worst prognosis is your anaplastic carcinoma of the thyroid. Okay. Now let's move to the next question. NK cells are positive for which of the following markers? Is NK cells, that is the natural killer cells, or positive for which of the following markers? All of us know about two markers, CD16 and CD56, which are always positive in your natural killer cells. Natural killer cells. What is the other name for this NK cells? That is the natural killer cells. And other name for this NK cells are null cells. Why they are called as null cells? Because they don't express a T cell marker or they don't express a B cell marker. Okay. T cell markers, yeah, very good. T cell markers also negative and B cell markers also negative. So they are called as null cells. So CD3 is ruled out. CD3 is ruled out. CD25 is for T regulatory cells. What is the role of the T regulatory cells? T regulatory cells are nothing but they prevent against the autoimmunity. Okay. And CD68 is actually a macrophage marker. Okay, monocyte macrophage lineage CD68. And it is the correct answer for here is the CD94. Okay, CD94 is nothing but it is a marker for the NK cells activating receptor. Okay, NK cells activating receptor. What is the role of this NK cells? NK cells plays a major role in killing the virus infected cells and also the tumor cells. Yes, I repeat it once again. NK cells, natural killer cells, plays a major role in killing the virus infected cells and the tumor cells. For this, the receptors have to be activated, and the activating receptor is nothing but NKG2D receptor. This receptor, the marker is the CD94. Okay, and there is a high chance, the chance of repetition is there. Okay, just learn this. All of the following clotting factors are elevated in pregnancy except, this is a straightforward question, and in pregnancy all the clotting factors are elevated except factor 11 and 13. This is a very important thing. Yes, very good, very good. All the clotting factors are elevated in pregnancy except 11 and 13. And remember, pregnancy is an hypercoagulable state. Why? Because so many clotting factors are elevated, including your factor 8. So pregnancy is a hypercoagulable state. Okay, remember this. And factor 11 and 13 alone are not elevated. This is a straightforward question. Which of the following is X-linked dominant disorder? Yes, now by this time you must be thorough about this autosomal dominant, autosomal recessive and these things. Yes, very good, very good. Out of the following options, the X-linked dominant disorder is the Rett syndrome. Rett syndrome. I hope by this time you would have revised your list of autosomal dominant disorders, and the mnemonic which I told you, that is autosomal dominant. What mnemonic I told you? Very powerful dominant. Okay, this dominant is very powerful dominant, and an additional H you will be remembering. So von Willebrand disease, von Hippel disease, just we saw in our clear cell RCC, pseudo hypoparathyroidism, and dominant dystrophia myotonica, osteogenesis imperfecta, Osler-Weber-Rendu, Marfan. Please remember one of the repeat question. Marfan is autosomal dominant. Intermittent porphyria, neurofibromatosis dominant. Okay, dominant. Achondroplasia, adult polycystic kidney disease, Noonan syndrome, tuberous sclerosis dominant. Remember, tuberous sclerosis, autosomal dominant, adult polycystic kidney disease are most commonly asked questions. Okay, then remember all this H. That is a hypercholesterolemia, Huntington chorea, hypertrophic obstructive cardiomyopathy, hereditary spherocytosis, hemolytic anemia. Please remember. Okay. Then HNPCC, hereditary non-polyposis colonic cancer, HHT, hereditary hemorrhagic telangiectasia. All these H are autosomal dominant. So if a disease first starts with H, now first think in your mind, it can be on autosomal dominant. Common diseases, these are all the things. Okay. Then autosomal recessive, I hope you remember this mnemonic A, B, C, D, E, F, G, H, I. Yes. Albinism, ataxia, telangiectasia, alkaptonuria. And one peculiar thing about this autosomal recessive is it is actually mostly the enzyme deficiency disorders, Okay. Then beta thalassemia, cystic fibrosis, congenital adrenal hyperplasia, then distal spinal muscular atrophy, Dubin-Johnson, emphysema, that is alpha-1 antitrypsin deficiency, Friedreich ataxia, galactosemia, glycogen storage, hemochromatosis, homocystinuria, and remember, inborn errors of metabolism, most of the lysosomal storage disorders, okay, that enzyme deficiency, it is autosomal recessive disorder. Yes. And you know this X-linked recessive, that is the mnemonic Lady Hardinge College girls never care for about foolish words. Okay. Lady Hardinge College girls. Okay. Lady Hardinge College girls don't carry or care about foolish words. Leishman. So the most important asked question is the X-linked recessive disorder. We know hemophilia. Please remember, most of the lysosomal storage disorders, inborn errors of metabolism, are autosomal recessive, I told. Hunter syndrome is an exception. Hunter is an exception. It is X-linked recessive. Hunter means also you will be remembering this one will be having a clear cornea. Rest of the other mucopolysaccharidosis will be having a hazy or cloudy cornea. The cornea will be looking very cloudy or haziness will be there. But in hunter has to hunt the animals, no? So remember like that. So hunter will have a clear cornea. Then the chronic granulomatous disease, then G6PD deficiency, color blindness. So fragile X, Biscott Aldrich. So all these things are X-linked recessive. Then only there are few X-linked dominant condition, that is vitamin D resistant rickets, X-linked hypophosphatemia, Rett syndrome, which is asked in our question, incontinentia pigmenti, and Alports. Remember students, actually this autosomal dominant recessive, the mode of inheritance, as well as the special strains, or something like an evergreen topic. Okay, evergreen topic, and every examiner's favorite thing. So you should be very thorough about this, about the mode of inheritance as well as the special strains. Okay, at least you can get it even as one of the option that can rule out, eliminate one option, or pick up one option. So this terminologies and this inheritance things you have to definitely learn. Okay. Then moving on to the next question. A 45-year-old female presented with easy fatigability, pallor, and hemoglobin was 6 grams per deciliter. What is the most likely finding in the peripheral smear? Yes, the patient is a female. And easy fatigability. Fatigability, that means tiredness and weakness is there. And pallor. So the patient is having an anemia. And the hemoglobin, they are saying it as a 6 grams per deciliter. And they are asking you most likely finding in the peripheral smear. So moving on to this target cells. One of the option is target cells. So target cells is a non-specific finding. It can be seen in thalassemia. It can be seen in iron deficiency anemia. So it is a non-specific, and hemoglobinopathies it can be seen. So this target cells is a non-specific finding, and with this anemia, and we cannot say that the target cells are seen like that. It can be seen in anything. And poikilocytosis is a terminology that is actually tells you that variation in the shape of the RBCs. Poikilocytosis is nothing but variation in the shape. Variation in the size is called as anisocytosis. Variation in the shape is called as poikilocytosis. So that doesn't give you any much clue about this. And coming to these two options, and the most commonest anemia worldwide and also among the Indian females, Indian female presenting with anemia in a reproductive age group, and think of It is iron deficiency anemia, which is the commonest one, and usually it will be having microcytic hypochromic blood picture. Okay, that is the based upon the commonest presentation, we are choosing this option, microcytic hypochromic. Okay. Which of the next question? Which of the following is not seen in pleomorphic adenoma? Is not seen in pleomorphic adenoma. That means what? Pleomorphic adenoma is the most common benign tumor, salivary gland tumor, benign salivary gland tumor. What is the other name for pleomorphic adenoma? It is called as a mixed tumor. Mixed tumor. What do you mean by mixed tumor? That means it has epithelial component as well as some mesenchymal elements also, mesenchymal components also, epithelial components. What are the epithelial components? Yes, you are getting this myoepithelial cells, which can be seen in a pleomorphic adenoma. Pleomorphic adenoma, mesenchymal component, mesenchymal tissue sort of thing. So chondroid differentiation can be the chondroid, like a cartilaginous matrix. Yes, you can see here. It is the typical appearance histopathological image of the pleomorphic adenoma. So these are all the epithelial cells, that is the bluish cells, no? So these are all the epithelial cells. And can you see this chondroid or chondromyxoid, something like a myxoid, jelly-like, as well as like a cartilaginous bluish tinge. So this is nothing but this is the chondromyxoid matrix. So with this, you can know that chondroid myxoid matrix is seen and the epithelial elements is also seen. Epithelial elements is also seen. Coming to the other option, perineural invasion and keratin pearl formation. You must have heard the word keratin pearl in context to your squamous cell carcinoma. So you must be wondering, so squamous cell carcinoma only keratin pearl will be seen. No, will it be seen in pleomorphic adenoma? But please remember, keratin pearl is seen in squamous cell carcinoma, but it is not specific for squamous cell carcinoma. Say, for example, in pleomorphic adenoma, which has undergone the squamous metaplasia. Yes, squamous metaplasia, that is the epithelium can get converted into squamous metaplasia in some cases of pleomorphic adenoma. So those cases will have keratin pearl formation. Those cases will have keratin pearl formation. But what is not usually seen is your perineural invasion. This perineural invasion, actually, it is a feature of malignancy. Yes, invasion is a feature of malignancy. But our pleomorphic adenoma is actually a benign tumor. Okay, perineural invasion usually you will be seeing in malignant tumors, malignant salivary gland tumors like your adenoid cystic carcinoma, not in a benign tumor like your pleomorphic adenoma. So this is perineural invasion is not seen. All the other things are seen in pleomorphic adenoma. Okay. Moving on to the next questions. Neurosecretory bodies are seen in all except. The options are medullary carcinoma thyroid, pituitary adenoma, paraganglioma, adrenal cortical tumor. Yes. What are these neurosecretory bodies? Neurosecretory bodies are nothing but actually these are already which can be appreciated in a cell mostly in the electron microscopy or even in your histopathological things. This will be having some granular appearance. Okay, some granular appearance. This neurosecretory bodies, if it is excess, that is giving you that granular appearance, then the nuclear chromatin is called as a salt and pepper chromatin. Salt and pepper. What is this salt and pepper? So that is pepper will be having small this blue black color things. No, so these are the granules which contains the secretory bodies. Okay, they contain the secretions. So neurosecretory bodies, obviously this medullary thyroid carcinoma, neural crust. Okay, parafollicular C cells derived from neural crust. It will be seen in medullary carcinoma thyroid. Pituitary adenoma has a secretory function. So definitely neurosecretory bodies can be seen here. Of course, paraganglioma. What is the commonest example for the paraganglioma? It is a pheochromocytoma. Yes, pheochromocytoma. So pheochromocytoma, you know that there is a marker, synaptophysin, chromogranin, all these markers. So they will be stored, that elements will be stored in the neurosecretory bodies. So paraganglioma also, you will be seeing this neurosecretory bodies. But in an adrenal cortical tumor, you will not see the Neurosecretory bodies. Neurosecretory bodies. Okay. Moving on to the next question. Which one of the following is familial? Yes, this is a very straightforward question. And obviously, compared to myopia or primary open-angle glaucoma, retinitis pigmentosa, the best option we can choose here is the retinoblastoma. Retinoblastoma. You know that retinoblastoma, actually the RB gene. RB gene is a tumor suppressor gene. Which chromosome it is located? RB gene is located in which chromosome? 13q14. Okay. RB gene is located. It is a tumor suppressor gene. It is located in 13q14. And it is called as the governor